Good afternoon, and welcome to the Health Cafe by the Primary Care Network on Diabetes. I am Carmen Wayanko, and I'm a registered nurse and certified diabetes educator. And with me, I also have, please introduce yourself, Doctor.
Hi, I'm Dr. Nath. I'm one of the family physicians in Red Deer, and I'm also on the PCN board of directors.
Next slide. The Red Deer PCN acknowledges that we work on Treaty 7, Treaty 6, and Métis ancestral lands, the gathering place of many Indigenous peoples. We honor our relationship with one another. Next slide.
Oh,
Here
we've
is
already
our,
done,
yeah,
yeah,
we've already
the
done this part. This
presentation.
is
Okay.
us and our credentials. So we'll move on to the next slide. Here are our learning objectives. So first of all, we want to describe the concept of glucose regulation, and then noticing risk factors for impaired glucose regulation. Next, we want to recognize when an individual has compromised glucose regulation, and then differentiate between type 1 and type 2 diabetes, identify causes, symptoms, screening, labs, prediabetes, and prevention. And finally, we will address treatment, lifestyle, medications, targets, and monitoring. Next slide. These are some of our references. For more than 25 years, Diabetes Canada has authored and put together guidelines for Canadian practitioners and patients for maximum health with diabetes. They were updated every 5 years in the past, but with electronic versions and the fast pace of medical knowledge, the updates are happening to different topics several times a year now. The Calgary diabetes educators do most of the education for community-based Alberta healthcare professionals who work in diabetes care. And next slide. To begin with, I would like to just show you a simple slide that shows us all of the organs involved in digesting of food, which will become an important discussion for later on today. So foods we eat are digested to produce glucose that we need for energy. A steady stream of glucose or fuel is provided by the liver as is needed to help keep all the cells in our bodies alive and functioning. The organs involved in this process include digestive tract, pancreas, blood vessels, and liver. Next slide. Simply put, normal glucose regulation involves the consumption of food as fuel, which is then transported throughout the body for cellular energy. Foods we eat are processed into a form of glucose that enters the blood. Blood glucose rises as a result. At the same time, part of the glucose we eat will also be stored in the liver because one of the jobs of the liver is to provide the body with a steady stream of glucose into our blood, especially during those times that we're not eating, such as overnight and in between meals. This is such an important process, we would not survive a day without it. As blood glucose rises, the pancreas secretes insulin in aid in glucose being transported out of the blood into the cell. Insulin acts on the cells to create a portal for glucose to enter the cell. This is like a lock and key analogy, where insulin is the key that unlocks the cell to let blood sugar into the cell. If we have unexpected activity or delay in fueling, we have our liver to give us stored glucose, and the pancreas is also capable of holding back on insulin and secreting glucagon, two hormones we'll talk about more later, to adjust insulin automatically to prevent low blood sugar. Next slide. So let's take a closer look at the pancreas. As one can see from the diagram, The pancreas is a complex organ containing cells in the islets of Langerhans where different cells exist. The beta cells are where insulin is made. In fact, the moment food hits our tongue, the beta cells will start to secrete insulin. The alpha cells make glucagon, which is a hormone that raises blood sugar. So the alpha and beta cells complement each other in the task of regulating glucose. It's like a thermostat. The pancreas will secrete and hold back insulin and glucagon to reach a state of homeostasis. Homeostasis means that everything is regulated at exactly the right amounts. There are many other pancreatic and bodily hormones that you may have heard of already, which are involved in appetite, hunger, satiety, such as ghrelin and others. Somatostatin from the delta is what we call an inhibitory hormone, and this helps the body hold back on insulin and or glucagon during times when blood sugar is changing rapidly. Next slide, please. Now that we understand glucose metabolism in the non-diabetes state, let's talk about what's going on in the body when there is diabetes. So we'll discuss the differences in detail later, but just to get started there, here are some basic definitions that you can always come back to. So type 1 diabetes, type 2 diabetes, gestational diabetes, and of course, other types. With type 1 or LADA, which we will discuss later, there's an absolute insulin deficiency caused by pancreatic beta cell destruction. In type 2, this may range from predominantly insulin resistance to insulin deficiency and also a state of insulin resistance. All of these terms we'll discuss later as we go. Gestational diabetes is glucose intolerance, which is first noticed during pregnancy. And there are some other types of diabetes which are much less common, such as genetic forms or perhaps diabetes caused by other factors such as pancreatic cancer or certain other medications. Next slide, please. Of course, the most common types of diabetes are type 1 and type 2 diabetes. As you can see, type 2 diabetes is much more prevalent than type 1 diabetes, and the age of onset is younger for type 1. Children with diabetes most commonly have type 1 diabetes, but in recent years there has been more children being diagnosed with type 2. Diabetes Canada has a prevalence of diabetes being 11 million Canadians at this time. The cost to healthcare in Canada is $30 billion per year to treat people with diabetes. Next slide, please. In type 1 diabetes, there is an absolute stop to insulin production in the body, most often caused by an autoimmune attack on the pancreas. We don't know 100% the reason for this, but we often think it may start with something viral or environmental. Sometimes when we have looked back in a patient's health history prior to having developed type 1 diabetes, they will often tell us they've had some kind of virus. We're very sick, but it's still a mystery as to what causes the body to have this autoimmune reaction where beta cells are destroyed. In the pediatric and young adult presentation, symptoms of diabetes usually have a very abrupt presentation, and the patient will go from feeling quite normal to very unwell within days. There is another type of type 1 diabetes called LADA, or latent autoimmune diabetes of adults, which could occur over a much longer time frame with symptoms being less severe. The adult who presents with LADA is usually over 25 years old, but we have seen in the literature that type 1 diabetes can present up into the 8th decade of life. LADA can very commonly be misdiagnosed as type 2 diabetes, Next slide. Causes of type 1 diabetes, as I was saying before, mostly unknown, thought to be viral or environmental, causes an autoimmune which destroys the beta cells in the pancreas. There are some links to genetic predisposition, although many people with type 1 have no family history of it. People of all ethnic backgrounds can have type 1 diabetes, although it's more common in people living north of the equator. Next slide. So the symptoms of type 1 diabetes are as pictured here, and they include frequent urination, increased thirst, plus fatigue, hunger, blurred vision, weight loss, and irritability. These symptoms actually make sense when we think about high blood glucose, which is thick, syrupy, and abrasive, and the cells are not receiving any glucose. So the body is essentially sending messages to the brain that it is starving, even though the person is eating and the blood sugar is high. Without the insulin, the sugar remains in the glucose and not be moved to nourish the cell. The body is always trying to normalize and create balance, that being the state of homeostasis we discussed before. So increased thirst and urination is to try to thin the blood, and the hunger, weight loss, and fatigue is all because the cells are not receiving glucose because there's no insulin to carry it into the cells. As this goes unrecognized for a while, the person with new type 1 diabetes is at high risk for DKA or diabetic ketoacidosis. Next slide. Above are some pictures of some of the basics that are needed for the treatment of type 1 diabetes, including insulin. Insulin is absolutely needed to treat type 1 diabetes. We have a picture of low glucose treatments because taking insulin by injection is also very difficult to manage while the person is learning, and also is not as easy as pancreas does it. We have blood glucose meters, and the little yellow canister and nasal spray you see there is kind of the latest form of glucagon, which can be very helpful in a period of severe low blood sugar. Next slide, please. So with type 2 diabetes, most often starts at the cellular level with insulin resistance. And you can see in the bottom of the slide there, we have a picture of insulin holding a sugar cube, offering it to the cell, and the cell says no. So it's just a comical representation, but believe me, it's not very comical when people are trying to manage this. So as usual, food is consumed. This is kind of the pathophysiology of type 2 diabetes. So food is consumed, the liver is providing glucose when needed, blood sugar rises, and the pancreas is making insulin. But suddenly, the cells are not accepting the insulin, and glucose stays in the blood. It is as if someone has come along and changed the locks on the cell, and insulin is no longer fitting as the key to unlock the cells and let the insulin carry the glucose in. As a result, the pancreas starts to work overtime, and what used to take a little bit of insulin to move glucose out of the blood into the cells now takes a lot. This process of overproducing insulin can go on for up to 10 years, and even a lab draw of the glucose at that time could be normal if the pancreas is still overproducing and still moving the glucose along. Or the blood levels could show pre-diabetic levels if drawn during this time. Eventually, though, the pancreas will get tired out and not be able to make as much insulin. It is estimated that by the time a person is diagnosed, about half of those pancreatic insulin cells could potentially be burnt out and not working. Because the liver also has insulin resistance, it is not functioning as well as it should, And the result is that the liver can dump stored glucose and further raise blood sugar. So in the presentation of type 2 diabetes, we actually have three problems: insulin resistance at the cellular level, the pooped out pancreas from overproducing insulin for a while, and leaky liver, all contributing to higher glucose. Next slide, please. Here are the causes of type 2 diabetes. So insulin resistance and or insulin deficiency are the two most common reasons for type 2 diabetes to occur. As you can see from the slide, there are many reasons for this. The key differences between type 1, type 2 diabetes, most often the pancreas is still able to make some insulin for type 2 diabetes. So insulin resistance, we know from Diabetes Canada that we can identify up to 70 genetic markers in insulin resistance and type 2 diabetes. Sedentary lifestyle plays a big part in insulin resistance. Overnutrition, overweight, and obesity absolutely can cause insulin resistance. Poor sleep can make matters worse. And there are some medications, actually quite a long list, that can cause some insulin resistance. And possibly one of the best examples would be something like steroids, like prednisone, that may be diagnosed for other conditions. So decreased pancreatic function or insulin deficiency could also be hereditary from trauma or illness or medications. Next slide, please. So the symptoms of type 2 diabetes, sometimes there are no symptoms for quite a long time. And I think that could be because a person has become used to, gradually increasing blood sugar, or it could be that the pancreas is working overtime, still taking care of business at that time. Otherwise, the symptoms of type 2 diabetes can be very much the same as type 1, usually less severe. So we have fatigue because the cells are not being energized, polyuria and polydipsia, so that means increased urine and increased thirst. Thrush from a high sugar environment could be genital infections, sores that won't heal, blurred vision, possible weight loss, and hunger. And I think that is it for my part of the presentation. So take it away, Dr. Neff.
No, thanks, Carmen, for the introductions and your expertise. So for the second half of the presentation, I wanted to concentrate on what family physicians do in their office while we look after patients, diabetic patients. Because the majority of what family physicians see are type 2 diabetics, I'm going to concentrate more so on type 2 diabetics. So first, I wanted to discuss screening for diabetes. So how do we go about doing that? Diabetes Canada recommends screening individuals who are 40 years and older every 3 years for diabetes, or for those with a high risk of developing diabetes in the future. And this is in individuals who have a 33% chance of developing diabetes. So how do you calculate what your risk is of developing diabetes? The Canadian Diabetes Risk Questionnaire exists, I think reduced to being called CAN-RISC. And this is a questionnaire that individuals, that physicians can use to calculate their risk of developing diabetes. From a family physician perspective, I find that the questionnaire is a bit cumbersome. It takes into account quite a few risk factors. This includes the patient's age, gender, whether they're on antihypertensive medications, family history. And so it does take a bit of time, I think, to review and to fill out with patients. And in doing so, I personally take a different approach. And I take kind of more a pragmatic approach to screening for diabetes in individuals. So what I do is I screen anyone with risk factors for type 2 diabetes. And these are the majority of the risk factors that you can see on the screen. So anyone who's 40 years and older, I screen. Those with a family history, especially first-degree relatives of type 2 diabetes, members of high-risk populations, specifically the Asians, Hispanics, South Asian population as well. Those who have a history of pre-diabetes, I screen regularly. If a woman has ever had gestational diabetes, I screen them often as well, usually every year. If a woman have ever had an infant who was very large, I also screen them as well. Other medical conditions that are associated with diabetes, I screen as well. That includes heart disease, strokes, heart attacks, those who have developed complications from diabetes in regards to the eyes, the kidneys, and their nerves. If an individual has issues with cholesterol, I also screen them. If they have coexisting high blood pressure, if they're overweight or obese, or if they're smoking, I also screen them for diabetes as well. And there are many other medical conditions that I screen individuals for diabetes, and just a few of them include polycystic ovarian syndrome, fatty liver due to alcohol or non-alcohol related issues. If they're on medications that is known to increase their blood sugars, such as prednisone, certain cholesterol pills called statins will actually increase the risk of developing diabetes, and also medications such as antipsychotics, which are known to increase an individual's weight and increase their risk of developing diabetes. So how do we diagnose diabetes in individuals? So it's normally done with a blood test. There are a few tests that we are able to order. One test is the fasting plasma glucose level. So in this test, individuals would fast for about 8 hours, and then their blood is drawn. If their blood sugar is equal to or more than 7, they are considered to be a diabetic. We also use a test called A1C, or hemoglobin A1C. It's just a random blood test that can be done anytime. And if their number is more than or equal to 6.5% in adults, they are considered to be a diabetic. So what is this A1C, or hemoglobin A1C? It's basically a marker that we use to, one, diagnose diabetes, and two, also monitor diabetes as well. Essentially, it's just red blood cells in the bloodstream that have glucose attached to them, and we measure the percentage of red blood cells that have glucose attached to them. So in individuals who have a high blood glucose level, there's more sugars that can attach to red blood cells. And over time, the A1C will increase as the blood sugars increase. So one can imagine that if you're a diabetic and you have lots of sugars flowing in the bloodstream, more gets attached to hemoglobin or red blood cells, and your A1C increases. So it gives us a pretty good idea of what your blood sugars are like over the span of about 3 months or so. Another method to diagnose diabetes is called the oral glucose tolerance test. So in this test, individuals would take a standardized sugar drink, and they have to wait in the lab for about 2 hours. They can't leave the lab. So I normally tell patients to bring something to keep them busy for 2 hours. Their blood is tested after 2 hours, and if their blood glucose is equal to or more than 11.1, that is diagnostic for diabetes. And another test is a random blood glucose taken anytime during the day. If it is more than 11.1, they are also considered diabetic. So in order to diagnose diabetes, you can't just have one number that is diagnostic for diabetes. You have to have two parameters on two separate occasions. So if someone has a random blood sugar of more than 11.1, and then we ask them to go to the lab again and have their A1C tested, and it's more than 6.5, then we can truly diagnose them as diabetic. So once you are diagnosed with diabetes, how does one monitor their blood sugars? So there's a couple of ways that that an individual can do that. I think most people are familiar with the capillary blood sugar monitoring system, where you poke your finger, a little bit of blood comes out, and there's a monitor that's, or rather a strip that sucks up the blood, and then the monitor reads what that blood sugar is at that time. I typically don't get new diabetics, type 1 diabetics that is, to test their blood sugars. However, I know that diabetes educators like Carmen will recommend checking blood sugars on a regular basis. And I think that's reasonable for the first probably 3 months or so. It just gives a patient an ability to understand what certain foods are raising their blood sugars and what type of activities can lower their blood sugars. One of the reasons why I don't recommend checking the blood sugars longer than that is because these pokes can be quite painful, and the test strips can be very expensive as well. And a newer way of checking an individual's blood sugar is actually with these, well, I think they call it the continuous blood sugar monitoring system. It's a small needle that's connected to a sticker that gets implanted just over the skin, but the sticker goes right into the skin, and it continuously measures the blood sugar. And it's quite convenient because these needles can stay in the skin for up to 14 days. So there's no poking, repeated poking of the finger, and you could monitor your blood sugars in real time with a smartphone or a monitoring device. So unfortunately, it can be very expensive to purchase these continuous monitoring systems. Okay, so why are we worried about diabetes? We're worried because of complications from diabetes. So diabetes can cause macrovascular or microvascular complications. So what do these mean? Macrovascular complications are complications that involves the big blood vessels in the body. So atherosclerosis is a complication, and that's just cholesterol buildup in the large arteries of the body. Coronary artery disease is atherosclerosis that involves the arteries of the heart. And once these arteries are blocked with cholesterol plaques, it can lead to such things as angina, which is chest pains, and myocardial infarctions, which are heart attacks. Cholesterol plaques can also build up in the arteries of the neck, as well as arteries of the brain, and this can cause strokes. So microvascular disease are diseases that involves the small arteries of the body. Nephropathy involves is a fancy word for saying kidney disease due to diabetes. And what happens is that the diabetes can unfortunately harm the blood vessels of the kidneys, and we often see protein spilling from the blood into the urine, which is not ideal, and it's a sign of kidney disease from diabetes. Neuropathy is damage to nerves from diabetes, and the damage can happen anywhere. Most often we see it in the feet, even in the hands, but really it can happen to any nerves in the body. Retinopathy is damage to the blood vessels of the eyes due to diabetes. Diabetes can also cause sexual dysfunction. So we do see it in men, in particular erectile dysfunction. And it can also cause gastroparesis. This is a slowing the inability, or rather stomach contents, which are slow to empty. And this can cause an individual to be nauseated, and it can cause abdominal pain, abdominal cramping. I just wanted to take a minute or so to discuss pre-diabetes, because we're seeing this quite a bit, especially during the COVID pandemic and now post the COVID pandemic. So pre-diabetes is it refers to impaired fasting glucose, or impaired glucose tolerance, or an A1C that is between 6 to 6.4, each of which places individuals at high risk of developing diabetes and its complications. So what do these terms mean exactly? Impaired fasting glucose is when an individual's blood glucose is between 6.1 to 6.9 after they have fasted for about 8 hours or more. Impaired glucose tolerance happens when an individual takes one of those standardized diabetes tests, a standardized drink, and their blood sugar is between 7.8 to 11.0 2 hours after taking the drink. And A1C is what we've discussed before. If their A1C is between 6.0 to 6.4, they're considered pre-diabetic. So how does one prevent pre-diabetes? It comes with intensive and structured healthy behavior interventions, ideally resulting in a loss of approximately 5% of your body weight, which can reduce the progression of pre-diabetes to diabetes by up to 60%. So very important to watch what you eat. And I often promote weight loss. It's really one of the best ways to prevent progression to diabetes. Another way is to start individuals on metformin. It can reduce the risk of developing diabetes by about 30%. So who do I offer metformin to? I offer it to individuals who are 60 years, or rather younger than 60 years old, if their BMI is more than 35, so an individual who is considered obese, or those with a women with a history of gestational diabetes. These are the three group of people who are found to benefit more from metformin to help prevent diabetes. So now that we've diagnosed an individual with diabetes, how do we treat them? So there's three pillars, one of which is diet. We always start with diet. Diet is important. Our goal is to achieve remission, and often by weight loss. So we recommend, in terms of diet, appropriate macros, portion control, low glycemic carbohydrates paired with balanced protein and fat. Exercise, again, becomes very important. Weight loss is important. I often recommend exercise more so for heart and lung health more than weight loss. We normally recommend at least 150 minutes of cardio activity per week and 2 to 3 strength sessions per week. And finally, medications for some individuals. So going back to nutrition, we often recommend good nutrition really for every individual, including diabetics. This is a picture on your left of a picture from the Canadian Food Guide of a 9-inch plate. And within that plate, every meal, we recommend half of the plate be covered with fruits and vegetables. 25% of the plate be covered with protein, with foods rich in protein. We often recommend protein from such things as seeds, lentils, beans. We don't recommend red meat very much. So red meat in moderation. Often we recommend more white meat. Protein from fish is often recommended more than red meat. Within that 25% of the plate, we also recommend low dairy, or rather low fat dairy products. And 25% of the plate should be covered with whole grain carbohydrates. So why is whole grain so important? This leads us to the glycemic index. Glycemic index is one way that we basically measure how quickly carbohydrates are processed, are metabolized in our body. So we typically want foods that have a low glycemic index. Glycemic index allows us to measure how quickly these carbohydrates are being metabolized in our body. So with a low glycemic index food, the food is slower, that is the carbohydrate is slower to be processed and metabolized, and this prevents glucose spike in our blood. With a glucose spike, it's very difficult for the pancreas to keep up secreting insulin. So we want just a steady flow of glucose in our bloodstream so that the pancreas can keep up with it. So you can see in the first two columns in green and yellow, these are the types of carbohydrates that we prefer diabetics consume. In a busy family medicine practice, I typically don't have a lot of time to go over nutrition therapy with my patients. So I often refer patients to experts like Carmen or diabetic educators, our nurses as well, so that they have ample time to discuss this with their patients. So having said that, Carmen, I'm not sure if there's anything more you'd like to go over with this slide.
I think you did a perfect job. That's pretty much exactly what I think is important also.
Great, excellent. Okay, so moving on to the medication aspect. There are several classes of medications that we use for diabetes, one of which is called metformin. Metformin helps to reduce glucose production from the liver. It increases insulin sensitivity as well. There's a new class called SGLT2 inhibitors. Some examples are Jardiance, Forxiga, Ivocana. This class promotes glucose excretion in the urine. So if we're able to pee out our glucose, we don't reabsorb it, and therefore our blood sugars, our blood glucose levels are much lower. Another class is GLP-1 receptor agonists. Some individuals may recognize some of the names here, Ozempic being very common and popular now. Victoza, Trulicity, Mounjaro is very new in Canada, and Rybelsus is an oral form of Ozempic. The first four are injectables, and again, Rybelsus is an oral form. So this class of medication increases glucose-dependent insulin secretion. It decreases inappropriate glucagon secretion. it increases beta cell growth and replication, and it slows gastric emptying, and it also decreases food intake, which helps to reduce a glucose load, and also weight loss as well. DPP-4 inhibitors, some examples are Onglyza, Januvia, Tradjenta. These are all brand names. They work just like the GLP-1 receptor agonists, but they're oral medications. There's a couple of classes as well, sulfonylureas, such as glyburide, glycoside, and meglitinides, such as repaglinide. How they work is they increase insulin secretion from the pancreas. And lastly, insulin is a big group on their own. So which medications do we typically start individuals on once they've been diagnosed with diabetes and require medication support? Metformin is often the first medication that's started. It's very inexpensive. It has been used for decades, and we know that it's safe to use with very minor side effects. Most of the side effects are GI side effects, so some individuals would develop an upset stomach, abdominal distension in some, mostly because of feeling gassy. And unfortunately, some individuals could also develop diarrhea on it. Most times we start individuals very low, and we increase the dose as they can tolerate. The medication itself, metformin, can help reduce cardiovascular events. So that's the macrovascular complications of the heart and the brain. And it also promotes some weight loss. SGLT2 inhibitors are safe for those with kidney disease or heart failure. So in those individuals with pre-existing kidney disease or kidney disease as a result of diabetes, we are using this class of medication to help protect the kidney. It also helps to protect the heart, because this class of medication has been shown to reduce cases of heart failure or heart failure requiring hospitalization. And the SGLT2 inhibitors can also promote some weight loss as well. The GLP-1 receptor agonists, we often use this in diabetics who have a pre-existing cardiovascular disease. If they've ever had heart attacks, it's a good medication to go on to. And it can also help reduce the risk of developing cardiovascular disease. So that's, again, heart attacks as well. And it promotes weight loss. So this group of this class of medication, the GLP-1 receptor agonists, interestingly enough, they discovered that medications like Ozempic have resulted in substantial weight loss, and therefore it is also marketed in the weight loss category. And Ozempic is actually marketed under a different name called Wegovy, which is not available in Canada yet as actually a weight loss medications. DPP-4 inhibitors, sulfonylureas, and meglitinides, they're not commonly used anymore because these medications haven't been found to help with the heart, to help reduce stroke or protect the kidneys. So they've been out of favor for quite some time, and I rarely, if ever, prescribe those classes of medications. And insulin is a big class of its own. There's lots of types of insulin. Is used typically, I typically use it actually as a last resort because it has a risk of causing low blood sugars, which is quite detrimental to diabetics. And it can cause weight gain. So gaining weight is counterproductive to the management of diabetes. So personally, I use it as a last resort. Sometimes, however, it's used at the initial diagnosis of diabetes, especially those that require hospitalization, especially when the blood sugars are very high or the A1C is very high. and they're coming in with what we call metabolic decompensation. So in those individuals, they have extreme weight loss, they're urinating often, and in certain cases, they've developed diabetic ketoacidosis. So that's a medical emergency where there's not enough insulin in the body, and as a result, the body is using lipids or fats as an energy source. The byproduct of metabolizing fat are ketones, and this causes the blood to be quite acidic, and patients are usually very sick. The best treatment in this scenario is insulin. Okay, so while treating patients for diabetes, what parameters do we need to monitor? Every 3 months, I would monitor their A1C. If their A1C is dropping, that's excellent. If the A1C is climbing, that's not great at all. I often measure their creatinine, which is a marker for kidney function. We always want to know if their kidneys are functioning okay, so that we can adjust their medications based on their kidney function. I also measure their urine albumin to creatinine ratio. As I mentioned, with diabetic nephropathy, you can spill protein into the urine. So the albumin to creatinine ratio is a marker of how much protein is being spilled into the urine, and hence a marker for diabetic nephropathy. On a yearly basis, I like to measure an individual's blood pressure. I do it more often if they are known to be, if they have a diagnosis of hypertension and on hypertensive medications. I refer patients often every year to the optometrist for a dilated eye exam to make sure there's no damage to the eyes. And I rely on my nurses to do sensory testing, most often the feet, to make sure patients haven't developed any nerve damage. Other tests include cholesterol. I often do this at the diagnosis of diabetes, and I do it every 5 years. If the patient is not taking a statin, which is a cholesterol pill to reduce cholesterol, I do it a bit different from Diabetes Canada because they recommend doing it every 1 to 3 years. I think personally that's a little bit too often. Okay, so the targets that we need to achieve in diabetic patients. An A1C of less than 7 is ideal for most patients. However, for those individuals who are older and frail, for example, a 70-year-old with a heart failure, history of heart attacks, COPD, who don't have a lot of years ahead of them, we typically recommend a higher target, anywhere between 7.5 to 8.5 or so. Younger individuals who we think can be treated a little bit more aggressively. Personally, I try to get their A1C to be closer to 6.5 or even 6, but we have to do that safely because we don't want to cause low blood sugars. And we'll talk some more about low blood sugars in a few slides. For those who have high blood pressure, I like to get their blood pressure down to less than 130/80. This helps to prevent heart attacks, strokes, and also damage to the kidneys. In terms of cholesterol, LDL cholesterol is termed the bad cholesterol. For individuals who have ever had a stroke or a heart attack, I try to get their LDL cholesterol to be less than 1.8. Diabetes Canada recommends a different value. They say less than 2 or 50% reduction from their baseline. Okay, so that's how we look after diabetic patients in our office. I just wanted to go through sick day medication. So I think this is important. When individuals are sick, it's easy to become dehydrated due to vomiting or diarrhea or reduced oral intake. when they're dehydrated, the kidneys don't work quite as well, and this can cause some medications to cause more harm than good. So these medications should be paused during sick days and then restarted once you have recovered. So we use the acronym SADMANS. And what do they stand for? The first one is sulfonylurea. So that's a diabetic medication that we talked about already. ACE inhibitors are blood pressure medications that we often use in diabetics to help protect the kidneys and for those who are hypertensive. Diuretics are water pills. Direct renin inhibitors, that's a class of blood pressure medications which we don't really use anymore. Metformin, we talked about being a diabetic medication. Angiotensin receptor blockers is another class of blood pressure medications, just like the ACE inhibitors. Non-steroidal anti-inflammatory drugs can be harmful during periods of dehydration. And these could be over the counter. They could be Aleve, Advil, ibuprofen. So they are quite common. SGLT2 inhibitors, again, is a diabetes medication that we've talked about. So if you look at the acronym, I think 4 of these medications are diabetes medications. So I want diabetic patients to be aware if they're feeling sick, dehydrated, they need to stop these medications and they can restart it once they've recovered. Lastly, I wanted to talk about a complication of diabetes, a major serious complication, and that's hypoglycemia, which is low blood sugars. So that's a blood sugar of 4 or lower. And this is the time where I believe that patients need to check their blood sugars. So what are the signs of low blood sugar? It could be relatively mild, starting from sweating, trembling, palpitations, heart racing, anxiety, feeling hungry, nausea, headache, or tingling, to more severe symptoms, which includes vision changes, drowsiness, difficulty speaking, and even being unconscious. So why does this happen? Why are the blood sugars so low? It could happen if patients have eaten less than they planned, or eaten later than normal, or if they've taken more medications than planned. Insulin is a big culprit. So if you accidentally give yourself too much insulin, that's going to cause your blood sugars to drop way too much. If they become more active, so increased activity causes your body to use more of the glucose in your blood, and then your blood glucose drops, and you could run into a hypoglycemic episode. Drinking alcohol in the past 24 hours can also cause your blood sugars to be too low. So the fear of having these lows is very common and normal in diabetics, especially those who are on insulin. So I'm sure it happens much more often in those who have type 1 diabetes. If you're experiencing these lows, we want to know about it. Please tell us, tell your physicians, tell your nurses, diabetes educators, pharmacists. We need to know that this is happening. So how do you treat yourself? You have to take a sugar load. So on the top part of the picture here, that gives you examples. So a tablespoon of honey, 2/3 cup of a juice box will help increase your blood sugar. You have to wait 15 minutes to recheck your blood sugar. If it's above 4 and your next meal is in the next hour, that's excellent. You don't have to do anything more. If your blood sugar is above 4 and your next meal is longer than an hour from that time, then you should take a bit more carbohydrate. So a slice of bread will do, and it's recommended to use, or rather to also take it with a piece of cheese or peanut butter to slow the absorption of the starch. And if your blood sugar is still less than 4, After checking it again, then you have to repeat the process, take another sugar load. And you definitely should not be driving when you have low blood sugar. Okay, so that comes to the conclusion of our diabetes presentation. I want to thank everyone who has viewed this presentation. If you have any questions, you can contact the PCN through email, or you can give us a call, and the phone number is on the screen. Thanks for your time.